Good morning. We've heard a lot of talk about the power of the story, and obviously you would have to be brain dead to not be unbelievably moved by this. My name is Bill Callahan. I am an obstetrician and gynecologist. I've been for a little over 30 years. The first half of my career I spent in general obstetrics and gynecology, helping babies come into the world, taking care of women. In the second half of the year, I retrained as an epidemiologist, and now I currently work in the Division of Reproductive Health at the Centers for Disease Control and Prevention. My charge is to do some accounting. And I don't apologize about that. I'm an unabashed counter. One of the first things I heard from somebody named Jim Marks, who's at Robert Wood Johnson Foundation now, when I first came to CDC, he said that a society measures what it values. In my profession, this is what I value. I value the lives of women and children and families. And so my charge is to account for the women that died. Joan Hayden was one of about 700 women every year who come into pregnancy and don't survive it. As many as another 70,000 women may survive their pregnancy, but there are severe complications. What we're going to try to do this morning, we've put together a panel of folks that are all coming at this from different perspectives, and that's critical. It's important that we hear the voice of the patient, the voice of the advocate, the voice of medicine, to try to understand why does this happen in the United States of America? Why do women die for no other reason than they became pregnant? And what can we do to prevent that? What do we know right now that we can put into place and say, this is the low-hanging fruit? We can fix this part of this right now, and where do we need to go in the future? So without further ado, I'm going to ask Eleni and Edna and Priya and Todd and Elliot to come up, and we'll have a conversation about this. So I'm going to ask our panel to introduce themselves. I think it's kind of boring to read people's bios and their perspective on who they are and why they're on the panel, what brought them to this place in time, and their interest in the subject. So we'll start at the end with Todd.
My name is Todd Hyde. I'm a patient advocate at this point. I guess you saw the story that I just told, and I was kind of brought into this by the situation, but I've been linked with Eleni and the Preeclampsia Foundation since Joan collapsed, and even before she died, Eleni has been a part of this. So I like to come out and tell Joan's story and kind of bring the human side to it.
Hi, my name's Priya Agrawal. I'm an obstetrician and gynecologist and women's health advocate. I worked with Atul Gawande in the World Health Organization on the Safe Childbirth Checklist and really have been obsessed with quality and patient safety, but always in the developing world. And it was really when I became executive director of Merck for Mothers, which is Merck's $500 million 10-year commitment to stopping these preventable maternal deaths, when I started hearing stories like yourself and data from experts on this panel that actually this wasn't just a developing world issue. And US became one of our priority countries in our 30-country portfolio. So that's why I'm here today.
My name is Edna Adan Ismail. I'm a midwife. I have spent a long career with the United Nations, WHO, training midwives around the world, And then I retired 18 years ago, went home to my country, Somaliland, where we had no obstetricians, gynecologists, no midwives, and of course, a country that had been at war. Every health facility had been destroyed, and it had the highest maternal mortality rate in the world. And my option was to retire somewhere, probably a beautiful place like here, or to recycle my entire life, go home, build a small maternity hospital. I thought a maternity hospital, which has now turned out to be a referral hospital, a teaching hospital, where we train midwives, and where I'm trying to reach my target of training 1,000 midwives for Somaliland. And if God in His grace gives me time and life, to do something about training midwives, 1 million midwives for Africa, because my continent, Africa, needs midwives, needs doctors, yes. But I don't know how to train doctors. I don't know how to train obstetricians and gynecologists. We don't have the hospitals. But if we can train midwives who can be in villages, who we recruit from the villages themselves to come and have a training of 2 years or 3 years, and then go back to their community, they can do a lot. And my humble little hospital, built in a country that does not even exist on your maps, has reduced maternal mortality of my people to 1/4 of the national average. And in 2012, we have about 150 deliveries a month. And in 2012, we had 0 maternal deaths. It was too soon to celebrate because on the 3rd of 2013, we lost our first mother for that year. But we've lost, out of 18,000 women we've delivered, we've lost 54 mothers. And it's 54 mothers too many, because many of them, the majority of them, died of eclampsia. Many of them died of infections. No woman should die of an infection. No woman should die of a ruptured uterus. No woman should die of causes that are so easily preventable in your countries. So how we're trying to address that problem is by the simple training of women to help other women, and encouraging women education, women's literacy, and wherever we can, women's voice in what to do about their lives. And thank you for inviting me. Thank you.
My name is Elliot Main. I'm an OBGYN that specializes in complicated pregnancies, maternal fetal medicine. So I'm the kind of person that sees women with eclampsia, women with severe hemorrhages, severe infections. I've worked, though, in a larger scale in terms of quality improvement, not only in my very large hospital in San Francisco, 6,000 deliveries a year, to a very large health system of 40,000 births a year. And then the state of California noted in 2006 that our maternal mortality rate in California was on the rise. It had doubled, as had the US as a whole in the last 5 years previously. And so they asked me to put together a maternal mortality review for the state of California, which had never been done in our 150-year history. You know, we had been cruising along thinking that we were doing just fine year over year. We were getting better and better, but the numbers didn't add up. So we established a maternal review in California, but took a little different tact. So we weren't just looking at the epidemiology of it, but really what were the reasons that the women were dying? What could we do differently as a quality improvement project? So this was a marriage both of data and epidemiology with quality improvement. And then we've turned that into a series of action programs that we'll talk about here. But you're right, and everywhere around the world, women are still dying of eclampsia, of hemorrhage, of sepsis, and they shouldn't anywhere in the world. So thank you again for your efforts.
My name is Eleni Tsigas, and my official title is Executive Director of the Preeclampsia Foundation. But I am first and foremost a mother. And I'm a mother who suffered severe preeclampsia twice and lost my baby daughter through errors. Once my husband and I had gotten past the terrible tragedy of losing a child, which no parent should ever have to undergo, we took some steps to engage with our hospital to try to address some of the errors that we had encountered. But it quickly became apparent to me that this issue of preeclampsia was not just something that I had suffered, and that the fundamental issues, the fundamental challenges were much bigger than me and my story. And so today I lead the Preeclampsia Foundation, which is a patient advocacy organization largely driven around research and education, because it is an issue that does not have a known etiology at this point. There is no slam dunk cure for it, despite what Todd and others have been told. Delivery might halt or start to slow down and reverse the disease progression, but that's hardly a cure. And so we do need to invest in research. There is a long-term view of what we need to do for this issue. But in the meantime, and this is a big part of the Foundation's mission, in the meantime, there are so many things that we do know how to do and how to do them better to save lives. And it's not just about saving lives, it's also just about reducing the morbidity, the near misses, the adverse outcomes, some of them physical, some of them emotional, to the mother and to the baby. And ultimately, one of the things that makes the Preeclampsia Foundation kind of unique as disease organizations is that we're dealing with two patients, the mother and the baby. And our goal, as is the goal of all mothers, is having a healthy pregnancy with a healthy outcome for both baby and mother. So that's a big part of our initiative, and we'll talk more about some of the details today, but that's a brief intro.
So, thank you all, and I think you can see that this is a fairly, not just wise, but eclectic panel of folks that are looking at this through different lenses, and that's what we need. I want to get back to preeclampsia in a few minutes, because I think it's kind of a paradigm disease process for what we see in critically ill pregnant women. But just to kind of provide a bit of context, one of the things that's difficult in talking about obstetric mortality or maternal mortality is that it's not just one thing. These are pregnant women who die from a variety of causes. So what we see is about 10% of women in the United States still die, Edna, from hemorrhage. We know how to treat hemorrhage, but women still die. About 10% of women who die from hypertensive disorders. About 10% die from venous thromboembolisms. About 10, 11%, 12% sometimes die from sepsis. These are things that we sort of should know what to do. At the same time, we have to put out there that there are increasing numbers of women who are bringing with them into pregnancy everything that somebody brings with them. So we're seeing more and more women who are dying from complications of chronic diseases, particularly cardiovascular diseases in pregnancy. That's a new challenge for the obstetric community. By and large, we have been used to, for healthy young women coming into pregnancy and dealing with what happens to them as a result of pregnancy. Now we're seeing increasing proportions of people who are coming into pregnancy, bringing with them their diseases, and this is really much more challenging, especially when we have things like cardiovascular disease, which might not be, they might not walk in the door with a sign on their head and say they have underlying vascular disease. Pregnancy is a stress test, and it stresses almost all of body systems, and when things start to go wrong, the problems that they have will be manifest. So I want to throw out to the panel, so preeclampsia has been around forever. There's in Chicago Lying-in Hospital, there are these sets of relief sculptures dedicated to all of the folks who, kind of the great leaders in the history of obstetrics, and there's a blank one for whoever figures out what causes preeclampsia. So it's been around forever. As many as 5%, 6% of women may have preeclampsia at some level. So we just heard this story. what went wrong? We should know how to deal with this.
Who wants to start?
I'd like to, I know it can get complicated and there's multiple causes and we don't know what causes preeclampsia, but I think your story actually highlighted 3 really important things for this audience. And one is remembering that this is not just a developing world issue. And I say that because awareness is going to be critical around this. US is one of a handful of countries where the rates of maternal deaths are going up, not Sierra Leone, not Afghanistan, not India, but the US. And I'm so glad that you are talking about obstetric safety at this conference. The second thing that your story highlighted was timing. Right? So it happened in the postpartum period. Often we say, congratulations, how's the baby doing? And many of us, when we go and visit our friends, are all about baby breastfeeding, baby sleeping. Well, how many of you actually ask mum, how is she doing, both physically and mentally? 60% of maternal deaths in the US happen in the postpartum period. And I think we need to remember that mum is still at risk after she's delivered. The other piece about the timing on your video, and many patient safety folk will know this, transitions of care and step downs in care are really high risk moments. So when you transfer someone from intensive care to the ward, you have to make sure that handover is really, really strong. Well, that's the same when a woman leaves a hospital and goes home. There's no baby manual, unfortunately, yet. So actually, you know, in your story, if you'd been given the information, you actually are an empowered individual. You would have come back. You would have brought her earlier. There are things that we can do at the time of discharge. And then the third piece is about the preventability. So sure, we don't know the causes of preeclampsia, etc. But remember, 99% of maternal deaths globally are preventable. And though we don't have good data in the US, probably about 50% of them are preventable. And the stories like yours and the data show that information, patient education, and the ability to know your danger signs, the woman has to be part of the team. This isn't a woman under anesthetic. She can be part of the team that can save her own life. So I think this story really highlighted some critical things that we can do now to stop these preventable deaths by 2020.
Yeah, I would like to add that I totally agree with you. But then I would also like to throw in another evil, ignorance, harmful traditional practices, resistance to seek help from modern medicine. In my country, for instance, women are supposed to be big and fat and strong. This is kind of a drought insurance. It's a country that, you know, the rains fail, thin ones will die first. I mean, that's what they think. So when a woman is pregnant and she begins to put on weight, and then her face is puffy, her nose is puffy, her lips are puffy, her rings are getting tight. They say, oh, pregnancy agrees with her. She's putting on weight. She looks beautiful. She's never looked so well. Not knowing that all this puffiness is fluid retention and there is an underlying preeclampsia. And they don't take her to a hospital. Nobody checks her blood pressure. Nobody has a little sphygmo that would show that her blood pressure was rising. And then she starts to fit and have eclamptic fits and convulsions. This is evil spirits. It's nothing, it's probably the evil eye of the second wife. Nobody will think about checking her blood pressure, doing something about bringing her blood pressure down to safe levels. So when we have all the medical pathologies and all the medical risks, there's also that risk of ignorance, of not seeking help when help is available. Again, there's things like women not wanting to go against their mothers and their mothers-in-law. Women have always been delivered by other women. Why go to a man? Why go to a hospital? Women have always delivered babies. So there is that resistance, again, where help is available, to get the patients to come and to seek help where they could have been saved. Last comment that I would have about that is, who owns this woman's body? Who has the decision? When a woman needs to have a cesarean section, she has obstructed labor, the baby's lying sideways, it's not going to come out, she's going to die, the baby has almost died. Who gives permission? It's not her. It's not her. It could be her son, could be her husband, could be her father. The husband gives approval, her father comes and says, no, 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 you have authority over the baby, that's your child, but she is my daughter. I haven't given my permission. So very often we have to fight these cultures and traditions, and very often I say, now, which one of you is going to sign that this woman should die? You don't want her to be saved? Okay, she's your daughter, you don't want her to be saved? Well, sign for me that you want her to die. She's your daughter. I need to know where I stand. So very often we have to fight these situations that we may be able to overcome through education of women, education of girls, education of communities, building bridges to bring about confidence.
And I just want to add that's not unique. Maybe the nuances of it are unique to the developing world or to your particular country, but there are cultural norms and even individual. I mean, a lot of times I'm asked, well, what do women think about XYZ? And I'm like, we're all individuals. So to overgeneralize is not fair either, but I will tell you that the cultural norms of women either erring on the side of, I don't want to be the hypochondriac, I need to, I'm pregnant, I need to be tough, I need to tough this out, I'm not listening to that sixth sense because I'm pregnant. So resistance is something that we have even in this country. And the other thing that I would say is if a woman, she needs to be her own advocate, but often in the case of maternal health situations, she needs a strong advocate working on her behalf as well, particularly if she is out of it or on magnesium sulfate. I would love for Elliot to jump in here because what you were talking about, Priya, I think has a lot to do with what we've found out about the preventability of some of these issues.
Certainly. In our review in California of several hundred maternal deaths, there were themes that kept on cropping up that crossed causes. First of all, hemorrhage and preeclampsia, we thought were 70 to 90% preventable, the deaths from those, whereas other causes were maybe cardiovascular disease was a little harder. It occurred maybe months to 8 or 9 months after delivery from cardiomyopathy. But concentrating back on the major causes that we thought were preventable, the themes were apparent again and again, and they included not listening to the mother, first and foremost. Secondly, denial and delay were sort of the twin demons that we saw again and again in the healthcare system. Women are assumed to be healthy and normal, and even if they have a complication, most of the time they're going to get better. And so that lulls professionals into a denial that this is going to be something serious and just give it a little bit more time and it'll get better. And most of the time it will until it doesn't. And that's when, sort of a young person with good cardiovascular system can maintain their blood pressure, maintain their pulse by vasoconstriction, even when the blood volume gets lower and lower and lower until they essentially fall off the cliff in a very sudden way. And that's where we need to be more attentive as physicians and healthcare providers. But at the end of the day, we also need to empower women to understand what's going on, to look for warning signs, to be educated as they go home. When you look at Todd's wife, that was a pretty classic case in preeclampsia with pulmonary edema. I could diagnose that just looking at the story and so forth. And that is a complication that you see with preeclampsia that generally appears day 2 or 3 after delivery as you mobilize all the fluids in your body. So that was probably not a good time to be at home.
Yeah, no, not at all.
Yeah.
And consistency of treatment was a difficult thing for her. I mean, her OB resigned, passed it on to another person in the practice who diagnosed her, then went on vacation, passed her on to another person, then admitted by a high-risk doctor that saw her early in the morning and then passed her back to the other doctor who came back from vacation who did the delivery and then took off for the weekend, passed it back to another OB who then discharged her. So it was very frustrating.
So you're bringing up a really important point. We have I don't think anybody would deny, a very fragmented way of taking care of people. We need to fix that. I mean, the problem is that as we heard this morning, it's also the system we're living in. And we can't wait until it's fixed to say, okay, mission accomplished. So given this level of fragmentation, how do we put in, what kinds of systems do we need that will allow it for a woman to have a baby and not die, just like we expect to get in an airplane and it not fall out of the sky? These 700 women, that's about 4 stretch 737s falling out of the sky every year, and we would not tolerate that.
Well, our approach for quality improvement maternity care in California has been to identify the areas of preventability, and then to develop quality toolkits for them, for hemorrhage, for preeclampsia, and now for cardiovascular disease, that encompass basically having the safety facilities in place, the safety tools, but also having a common protocol for dealing with an emergency in obstetrics. We accept those very commonly for a cardiovascular collapse, a code, or a neonatal resuscitation, but we haven't had those in obstetrics. Everybody is doing their own thing, but every physician, every nurse is playing from a different playbook. So what we've worked with in California, and now is being taken up nationally through the American College of OBGYN, as well as the Nursing and Midwife Associations, and a variety of other partners, is to have some standard approaches to emergencies, like preeclampsia, like hemorrhage. And what we've seen in California, as we've put those into play over the last 5 years, is that the maternal mortality in California is halved. The maternal mortality rate went up in California. We used to be the same as the US. The US is now, depending on how you calculate the numbers, around 18 to 20 or a little bit more. We're down to 6 and 7 for the last 3 years in California. So that's really a big deal to be able to do that.
Yeah, not to interrupt, I mean, this should be front page news.
Yeah. But it is by working in a collaborative way with not only all the provider groups, nurses, physicians, midwives, but also with the hospital association, with the public health department, with everyone we can think of in California who has has an interest in maternity care. And it really does take a village to do these kinds of changes, and that's what we are really promoting. But it's one thing to have a protocol, but that doesn't really get you that far unless you have drills and debriefs and make it a continual learning experience. And that's what we've been working on with our facilities in California.
Well, and I think the other thing that's been nice about these bundles that have been put together is, yes, there are protocols, but then there are tools kind of at the ready to help states or hospital systems or whoever's going to implement them to actually address each of these areas. And I love the way that it's been grouped into the readiness, recognition, response, and reporting. And those 4 R's have become kind of our lingo for every obstetric situation, that you need to have those 4 R's ready to be addressed, and that we've had tools in place. So for the Preeclampsia Foundation, one of the big pieces we've contributed is patient education, and actually working with health literacy experts to address the fact that you can't just hand a woman a pamphlet and expect her to read it, and then we've solved all of this lack of education problem. There really has to be an identification that people understand health information differently. You've got to actually make it, available in the simplest format possible, and then it has to be universally applied. And so that's one piece of a very, very beautiful bundle that's been put together.
When we first started, we actually didn't come in with solutions because we had only started our US work so early and we weren't expecting to be here. So we spoke to all of you, and there was like 4 areas that we needed to work. And there was, first of all, it was what you said, Bill, which you treasure what you measure. And unlike most developed world settings, US wasn't looking at every single maternal death, doing a full review, including patients, et cetera, and then sharing that data across the country so they could learn. So we've been working with CDC and AmCHIP to make sure that a maternal death, which should be a never event, is fully evaluated so others can learn from it. I'm hoping CDC's kind of come out with a micro report this year of some of the state's findings. The second piece was what Elliot talked about, and he's had incredible success, and others, in the there's no code blue for obstetric emergencies. So creating that code blue and that bundle. And again, Elliot's seen the success in California. We've supported efforts in 4 other states. So we've covered 300 hospitals, and AIM's taking that forward. But, a plea to those in this room, every hospital should have those safety bundles. That's how we're really going to stop all preventable deaths. It's not enough to be in 5 states or 8 states. It shouldn't be a zip code lottery that if I get born in a state that happens to have these hospital bundles, then, I survive. The third piece is what you brought up, Bill, which is there is a rise in chronic diseases, and we have to face that fact. And so we're only taking this on in a very tiny way, but we've got to remember that care doesn't stop at the hospital or start at the hospital doors. And so how do we make sure that continuity of care from community to hospital and back is leveraged? And so we're just looking at 3 innovative models based in cities that look at women with chronic diseases and often other disorders like mental disorders that actually find the complex, fragmented healthcare system really difficult to navigate. How do we get women healthier before, during, and after pregnancy? And the fourth is just a good story. It's with A1, the nursing association that Elliot works with as well. And they identify the postpartum discharge point is really critical. And your story really highlights that. So they've developed, and will be coming out in March, with our support, a postpartum discharge checklist. So it's like the safety bundles that are for the provider. This is to ensure that that point where the woman and family is going to go back, they're really aware of what are the danger signs that should bring them back in. And most importantly, should they even be discharged right now? As you said, well, a woman looks healthy, I'm sure she can go. One little story that we just heard last week, a woman was given this checklist. She had the check, she was given the warning signs. She went back and she experienced the warm leg that anyone in this room knows is a sign of the impending pulmonary embolism, one of the 3 big killers of women in this country. So she comes back, she comes to the emergency room, she's waving this piece of paper and she's like, I'm supposed to come back, I know this is a problem. She gets diagnosed, she's about to have that fatal clot, she gets treated. So it's simple things that we can all do, and in this room you can scale up to make sure every woman at every hospital have these tools to hand.
So, go ahead.
I would like to share the experiences of my country again. We are the second institution in Hargeisa, the capital of over 1 million people, where there is a blood bank. We trained our first anaesthetists and graduated 7 only last year. We just completed a training of 4 junior doctors in how to perform safe cesarean sections. We don't have oxygen. Very often we need to buy oxygen from the ones who have welding machines. We don't have operating theaters, and when we do, we may not have electricity, we may not be able to sterilize our equipment. So you go back to the old boiling system. But all of these are all problems which, again, have another risk added to them. Female genital mutilation. So when we no eclampsia, no infection, but that baby is not coming out. And there is nobody there to open that infibulation that was caused by other women, by humans. The baby remains in the vulva, the prolonged second stage, and damages the urethra. So even if this woman survives, she is afflicted by a fate which is worse than death. Obstetrical fistula, she's leaking. She's not able to control her body fluids. So we have all of these factors that, again, become superimposed on the other medical and obstetrical problems. Boils down to the fact that there's got to be spread out areas where women can be taken to, accessible, reachable. Hopefully you have a road. Hopefully you will have means of transportation. Hopefully you will have somebody who will give consent that this woman be taken to a hospital and be helped. Hopefully you will have a blood bank. Hopefully you'll have an operating theater. Hopefully you'll have a surgeon who is competent to do the cesarean section. Hopefully he will have an anaesthetist. So all of these factors are superimposed, are all there, which contribute to the loss of life among our women.
And by the way, these 3 delays that you're describing, the delay to seek care, the delay to get to care, and the delay to get access to quality care, are not actually different from here. Like one of our programs is based in Camden, New Jersey, and I was shocked. I was saying, what are your problems? Like, let me try and understand what the landscape is. So we're standing outside the main hospital in Camden, New Jersey, and he says to me, he's like, the women in that housing project, they don't know when they should seek care. No one's gone into those housing projects to tell them that they need early prenatal care. Also, there's no public transport for them to get to the hospital that they can see from their window, and there is absolutely no way any cab service is going into that housing project. And the third, when they get to the hospital, and we're going to have some more data coming out on this, they don't necessarily get treated in a standardized manner and the quality of care that they deserve by being a human being. So the 3 delays that you're describing in Somaliland are actually what we're also seeing here. It's not that different.
So Priya raises the critical point and the critical challenge for Americans, I think, which is the disparity of outcomes. We've already talked about maternal mortality being rising in the United States, being at the highest level since the early 1970s. African Americans have 3 to 4 times higher rates of maternal mortality than any other racial or ethnic group. Including Hispanics, including Asians or whites, 3 to 4 times. That's a greater racial disparity of a public health outcome than any other. Yep. Any other. So infant mortality, cancer deaths are 1.5 to 2x. This is 3 to 4x. And
mortality is 1.5. It doesn't even track with infant mortality.
Yeah.
And this is when you adjust for income and education, by the way.
Yes.
A rich, educated black woman is still at higher risk than a rich, educated white woman. So this is not just an access
Actually,
issue.
a rich, educated black woman is at higher risk than a poor, uneducated white woman.
Right.
Yeah. So this is clearly a challenge to our public health system and to our clinical health system. And as part of our bundles is how are we going to be able to address at least the medical side of this. Priya's identified that we have social issues that are big, big barriers out there, but this is a challenge for America as a whole.
I don't know if any of you have seen our director, Tom Frieden's public health pyramid, and the way it works is it pyramids out with levels of intervention. So close to the top of the pyramid is personal empowerment and medical decision and medical care. That's very intensive and will have the least impact. At the bottom of the pyramid are the social determinants of health, where you will have the most impact, and yet it's part of our system that we continually ignore. We are fundamentally going to have to make changes in our society, just as we're going to have to make fundamental changes in the way we deliver care as part of the larger, more holistic way of looking at quality improvement. One of the questions that comes up, and as many of these questions, they kind of weave in and out, and you can tease out themes. And it may be because of our own myopia, because this is what we do for a living, but people, and every time I talk about this, and I've heard it from you, every time you talk about it, people are astonished at this problem, that maternal mortality is a problem, and that there are problems in care. What can we do? What should we be doing to put this in bigger headlines? At the same time, understanding that 4 million women a year give birth, 6 million of them women get pregnant, 4 million of them have a baby, and we don't want to create a culture of fear, because creating a culture of fear will undo everything that we're trying to do.
You know, this is one of the things that we get the most pushback on is, oh, I don't want to scare my women. We're over-medicalizing pregnancy. This is a natural process. And, you know, nowhere else with all these patient safety issues, nowhere else do you walk in with such an expectation of joy and this being such a natural part of life. To the discordance with then something going wrong is huge. But one of the biggest issues is, how do I educate my women without becoming an alarmist and making them run for the hills and shudder at the thought of getting pregnant? And I do think that there is a balance, and I think it varies because some women want a ton of information and want to know everything about their health condition, and others just give me the basics, don't overcomplicate this for me. But I will say that one of the things that I do say is scaring a woman never killed her. Not giving her the information she needed has. So at the end of the day, that's my fine line.
So there clearly is a lack of awareness that this is an issue, not only an issue of maternal death, but as Bill was saying at the beginning, severe maternal morbidity, which is 100-fold more common. In research that we have in press right now, the two major drivers of severe maternal morbidity is hemorrhage and preeclampsia. They account for 85% of that. So we're talking about the same issues that lead to death, that lead to severe morbidity, and the message needs to be out there. And that's where our friends in the media can really make a big impact. In fact, Eleni and I were just in an article in Cosmopolitan. Now you have a reason to go out and buy it, so that's okay. It was the January issue, but it was really focusing on a near miss from the patient perspective. It was her story, and it was very powerful. And stories really are important in medicine because I'm a data person, but as I work with hospitals and physicians, you have to have data and you have to have stories, and then you have to have what you can do about it. So you have to have the three parts, I really think: data, stories, and a plan.
Action plan.
Yeah, an action plan.
Well, and one of the things that Elliot knows, I kind of become the bee in everyone's bonnet on this issue, is don't underestimate the power of those stories actually contributing to the data. So in all of these, one of the things that I would challenge everybody in this room is, do you have a hospital level patient engagement plan, and do you have a case-specific patient engagement plan? Because hospitals forming patient advisory councils are great, and they have their role, and I absolutely support that. But then when you are doing that case analysis when something went wrong, are you asking the woman and or her family members to tell their story and to offer their observations and to give their patient perspective? Because I guarantee you it will be different than the nurses, the doulas, the midwives, the OBs, and the administrators. And there is information to be culled from that can contribute to the data when you're analyzing, okay, what went wrong? What do we need to do to fix this?
I'd love to hear from Todd how you feel about this whole concept of creating a culture of fear, because from our experience when we've started, like we've got our comms machine, something you can do in the private sector, ramping up. And every time they get the patient stories, normally journalists don't want to talk to Merck for like more than 15 minutes. And you definitely don't want to mention the name if you've got a good drug, and I understand that. But on this topic, it's unbelievable. The journalists will stay on the phone for an hour, hour and a half. Everyone has a story, and often they haven't been able to talk about it. And so what I'm noticing is that there's a secret society out there of women, some of whom don't know that they're a member of the secret society, many of whom don't want to be a member of this secret society, but they blame themselves because no one dies in pregnancy. There's no real issue. I go in, I deliver, and if something happens, so these are the people that have severe complications and live with them for decades, it must have been my fault. Because it can't have been the hospital's fault, because no one's talking about this issue. And so we're finding is we're sort of unwrapping the secret society and making it sounds terrible, but acceptable, that maybe it wasn't the woman's fault. Maybe the system is at fault. I actually think that's really powerful. And I'm not sure if you and your wife would have been scared to hear those stories, but in a way, I assume it would have been more empowering. But I'd love to hear what you think about, is it really true that we should all be worried about creating a fear culture?
It's a two-way conversation that you want to take place. You're in a hospital, you expect that things could go right, things could go wrong. That's just the nature of pregnancy. There's always that high-risk chance that you're going to end up at that high-risk hospital, which is where we ended up. And you kind of expect that those are the conversations you could have. This is what could happen. We're going to be doing all this to make everything fine for the baby, to ensure successful delivery. And you're just wanting those two-way conversations, but when they're just blowing through you, like I'm doing my rounds at 5:30 in the morning, I've got a 5-minute window for you. If your husband wants to be a part of this conversation, he's got to be there, otherwise I can't talk to him. And it never occurred for us. And again, I'm just speaking for myself on this one. But because of the organization that Eleni leads, I've met a lot of different women that have literally walked into the hospital time and time again, self-diagnosing. And you can't assume that they're educated, you can't assume that they're uneducated, but you have to talk to them the same. And you can't tell them they're wrong. You can't tell them, because their bodies are their bodies, they're listening to their own bodies. They know their bodies better than a lot of these doctors do. And there's one woman in particular I think would be great for this type of a forum, but she walked in 5 times on her own with her doctor saying, you don't need to be in here, and almost died, repeatedly. So it's very frustrating to hear the different stories, and I've kind of become a person that people talk to death about, which is interesting in its own right. But it's just, if I had just had that chance to have that connection with the doctor, to have that conversation while she was still alive, because she had developed such an adverse relationship with the doctor just because of the way he treated her, that she wanted to get out of the hospital.
Yeah.
Well, and this is why the advocacy role is so important. Is whoever that partner is, somebody else with that woman, because she's often in a compromised situation, and especially if you're sick or on magnesium sulfate or whatever.
But Eleni, what do you think about the role of media and grapevines and women's groups? Because one thing that I found we don't leverage in this country that we leverage a lot in other countries is that women talk. And I think that's a great thing. But like, women gossip and they talk. And if this issue is out there, like in the Cosmopolitan, it starts a conversation.
So
and
the
then
best
it
thing that
starts
ever
questions.
happened, the best thing that ever happened to awareness was Lady Sybil dying on Downton Abbey.
Right.
So we need to knock off a really popular character about once a year, and we'll be in great shape.
It certainly raised the visibility of Preeclampsia Foundation in one fell swoop.
But the conversations are super important, and the community building that happens around this. I mean, our community forum is extremely active. Facebook is extremely active. All these places are really active because peer-to-peer communications are highly valued by women, and so influencing them and their decision-making and their knowledge and their information, definitely, it's the social media, it's the peer-to-peer connection that really drives that. Although, because we've done national surveys now 2 years in a row to understand the awareness of this issue at a macro level and at a micro level. And one of the things that, I guess I shouldn't say it surprises us, but a woman's trust in her physician is still a high priority, and where she trusts the information that she's getting. That still ranks pretty high in all.
And that's why the system needs to interact with the community and the people.
Yeah, and you said the word, the system needs to interact with the woman, because it's not going to be sufficient to empower women if there's pushback from who she is communicating with.
We often say we can get them to the door, but if they're not met, receptively and appropriately.
So the lesson that we've seen again and again in many of our cases is that the presenting complaint is somewhat vague, and it's generally summed up as anxiousness. And anxiousness actually is a pretty serious sign at this point, because it may be low O2, it may be a variety of other signs, and maybe a lot of women have premonition type of symptoms that make them very anxious. And so the re-education there is that you can't blow off someone who's being anxious, that you really have to do a good exam and a good set of vital signs. And that's really a key step in this, because anxiousness is one of those things that's easy to dismiss, and we really can't see that.
Well, and the other thing is in OB, due diligence isn't all that expensive. We're not saying, oh, go get an MRI. We're saying take blood pressure and have her pee in a cup. This isn't hard or expensive.
And particularly in the peri and postpartum period, the O2 sat is actually a very important piece as well.
I mean, I think that's really important. This piece that what we're talking about is pretty low tech for a lot of things we're addressing. Now, a woman, despite all good care, could end up on a ventilator in an ICU with a bunch of lines, and that's what she is needed to do to save her life, and so she needs it. But for the most of what we're talking about, hemorrhage, hypertension, prompt recognition of hypertension. Prevention of venous thromboembolism and treating infections is pretty, bread and butter medicine. It's just doing it and doing it right at the right time.
You got to talk about hypertension and treating it. Because the data is just
Yeah,
astounding on this.
We run a big collaborative of 30, 40 hospitals in California, and really we're trying to identify how long it took to treat severe hypertension, which was over 160, over 110 diastolic, which are very high for pregnant women. And we were surprised at the very high number of sites that were taking well longer than an hour to start treatment. And we know the biggest cause of death in preeclampsia is stroke. And that's related to untreated severe hypertension. And people were coming up with all kinds of excuses not to do it. We want to prevent this or do that first. And that was, so there's a real improvement opportunity there. But I think our biggest challenge, if I may just go on for one more moment, our biggest challenge is how to scale up, and Priya was talking about this a little bit earlier, how to scale up from good pilot projects. My state has 500,000 births, 500,000 births in California. We were blessed with support from Merck to help reach all 250 hospitals in California. There are 4 million births in the United States, and so it's an order of magnitude again. And it's really the challenge in which the room can help is how we scale up to every state, every hospital in the country. And our professional societies are taking leadership on this. And CMS and others. Maternal Child Health Bureau is sponsoring a big project for 3 safety bundles in every hospital, every birthing facility, hospital or birthing center in the United States for hemorrhage, preeclampsia, and prevention of venous thromboembolism. So that's a national project right now that we really want to see implemented everywhere to have the safety bundles.
So we're only have a few minutes, and that's, I think, a good lead-in to kind of talk about that this, in my view, is not all gloom and doom. When I first met 15 years ago, Elliot and Eleni, we had a teeny little group of people that were trying to make noise about, look at these data, we need to do something about it. And in the past 5 years, there's been more action around this than at any time in my career. So if we could talk just a few minutes about what some of those things are, I'll lead off. And as Elliot alluded to, some of our national organizations are very involved in this. And now we have the Council on Women's, Council on Patient Safety and Women's Healthcare. It's a long name. But Safe Healthcare for Everywoman.org. And it is just blasts you with how much is happening in terms of looking at, that's where the bundles live. That's where the review of severe morbidity lives, what severe maternal morbidity is, how it's defined, how you would review those cases in every hospital. One of the things about the bundles that they all start out with is, this is what every place that delivers babies should have. They should have, it's not a script particularly, but every place that delivers babies should have a plan for hemorrhage, should have a plan for hypertension, should have a plan for venous thromboembolism prevention. And it's out there, it's going. The other thing that's happening is in a kind of a population health is states have started up, and Elliot's part of the California state quality collaborative, but perinatal quality collaboratives that have taken on issues around birthing for the most part, some of them on the neonatal side, some of them on the maternal side, and using standard principles, industrial principles, if you will, of continuous quality improvement and rapid feedback of data to inform the initiative that they're doing, have had successes. That we know that this is a way to improve quality of care. We're fortunate to be participating pretty actively with 6 states right now as they develop these platforms that I think will be able to be scaled up if we can show that they're sustainable. And to address the elephant in the room, and if we show that we can save money.
I would like to also mention the big problem of high parity. In my 55 years of midwifery, I think I have seen 2 or 3 women in my country who are having baby number not 5, not 6, not 10, not 15, 21. 21. And you say, well, look, I don't care if you have 500, but you cannot have a baby next year. You need to do something about not having a baby next year. And then, of course, the obstacle of, but if I stop having babies, my husband will divorce me. He'll find another wife who gives him more sons. So it's, again, overcoming resistance. Again, ignorance comes in. Again, resistance to modern medicine comes in. Women's position and empowerment comes in. So there's so many factors that need to be looked at and considered and solutions found for.
I'm going to put out some calls to action because we've been doing a lot of the work, and I think most of you need to now scale this up. So one, I would say if you're part of a hospital system, download those bundles for the 3 biggest killers of women in this country and make sure your teams are implementing them. It looks like you have to invest in quality, but quality actually ends up saving money. And if some of you want to start doing some of this costing analysis, I can commit that Merck's cost effectiveness analysis group can support that piece. Second, when the postpartum discharge checklist comes out in March, again, I know A1 would love to see hospitals adopt that. It will save and stop stories like this happening. We're seeing it in action right now. Third, if there's media people out there, we have a bank of stories and partners who have stories. We need to start sharing them more with people so we increase awareness. And fourth, data seems boring, but in this field, it's really important. We just did the first, I think, Bill, you supported it, New York City Department of Health did its first analysis of severe maternal morbidity, where shocking data is coming out. If you're part of a hospital system that has data, we have a model that you can put data in and come out with not only what is the impact of severe maternal morbidity, so the numbers in your hospital, but actually what it's costing your hospital. And New York City Department of Health is happy to share that model with others, so you can build an investment case for actually investing in stopping women dying while giving life. So they're my calls to action for you guys.
Just to underscore, it absolutely takes everyone in the room to do this, industry, clinical medicine, public health, and everybody and anybody we can think of. There's not a lot of money to support these kinds of activities, I'd have to say. Our public health departments in each state are struggling even to do maternal mortality reviews. Federal monies for Title V, which funds maternal child health programs, has been cut each and every year over the last 7 years. And so there's real opportunities to support these activities as well.
Actually, I do want to add one more on that pitch, which is CDC cannot mandate that states share their maternal death data, but if you're working in a state where you're doing maternal mortality reviews and want the country to benefit from what you're learning, please do pass it on to the CDC because they would be happy to collate it as part of the first micro report that will be coming out.
I mean, I have to say that our accounting for maternal mortality is not what it should be because of the way we do it, because we can't, an inability to demand that people send. There's not somebody sitting on a telephone in Atlanta saying a woman just died and here's her story. So we're in many ways using scotch tape and paper clips to try to, and a lot of really wonderful dedicated staff to try to discover and account for every woman who dies during pregnancy.
The other call to action that I would add to what Priya suggested, and Elliot has been talking about these bundles that have been created for the 3 leading causes. From a patient's perspective, I really want to encourage you. We've also created a bundle called the Patient, Family, and Staff Support Bundle, recognizing that when there is an adverse outcome, whether it's death or just a really bad outcome, all parties are deeply affected and need to be handled in a very sensitive, caring way. That includes staff, but definitely includes the patient and family and the emotional needs. There's really more and more evidence coming out now that there are PTSD. PTSD is a common result of some of these adverse outcomes. Again, you have to realize we're looking at a situation, you're juxtaposing the most joyful occasion in your life with the worst outcome, and emotionally, mentally, the mental health impact of that is pretty significant. So I would definitely encourage that as another area of focus. And then also just finding a way to listen to your women, that listen to your patient story. It's pervasive across all patient safety initiatives. But I will say that, I don't know, I'm looking at this, I know, myopically through the obstetric lens, but really listening to a woman, especially when she's not reporting something specific, but just says something doesn't feel right, it's not costly and it's not hard to really stop, look, and listen to what she's saying and investigate that. And that listening component also happens when you are looking for these quality improvement measures and incorporating her insights into what needs to be done.
So I'd like to thank you all for this. This, I think, was a very engaging conversation. I think and hope for you that this is what you wanted to hear. We think it's what you need to hear. And thank you all for your attention.
Yeah.